all, welcome to CARE Samvaad with me Mirchi Hemant and ee roju nato paatu unnaru Dr. Thota Venkata Sanjeev Gopal. Doctor, we've heard so much about you, at least with regards to the anesthesia, that Neno nato paatu our people across social media have a list of questions that we want to throw at you, Doctor.
Sure.
I hope you'll answer all of them with a lot of patience, please.
Surely, I'll do my best.
So the first question, that a general question that we always have is, what are these kinds of anesthesia that everybody talks about? They say regional, local, etc., etc. Can you please explain that for a layman like me?
Sure. Anesthesia is broadly defined as a temporary and reversible loss of consciousness, the loss of pain sensation, and also memory and certain reflexes, so that we can facilitate painless surgery for the patient. Anesthesia is broadly divided into two parts. One is general anesthesia, wherein a patient is put to sleep and therefore he or she is not aware of what's happening during the procedure. And the second sort of anesthesia is regional anesthesia, wherein an injection is given in the back to numb the lower half of the body, or an injection is given in the vicinity of a nerve or plexus to numb only that part of the body which requires surgery. Typically with regional anesthesia, the patient is awake, but we sedate them so that they are not anxious during the procedure. Another minor form of anesthesia is local anesthesia, wherein the numbing agent is injected exactly in the vicinity of the area where the surgery is being performed. And this is typically for very small surgeries like removal of a bump or suturing of a lacerated wound or extraction of an infected tooth. Yeah. So these are the three broad forms of anesthesia: general, regional, and local.
So I remember this one, Doctor. I mean, the injection was pretty painful. After that, I couldn't feel anything.
Yes.
And also, when you say these different kinds of anesthesia, Doctor, how do you categorize them? And as in terms of what to be given to which patient at what times and what levels?
Yeah. Mixing and matching the anesthetic to the patient and the surgery is very, very important. Now, there are some surgeries which can only be done under general anesthesia. So in such surgeries, we don't have a choice. For example, cardiac surgery, or most neurosurgeries involving the brain or spine, or most laparoscopic surgeries. Now, the other factor we take into consideration when we decide or draw up the anesthetic plan is the overall health condition of the patient. Sometimes a patient may be unfit for general anesthesia, in which case we may have to necessarily choose a regional anesthesia for this patient. So it again depends broadly on two factors. One, the type of surgery, and two, the overall health condition of the patient.
And what are the risk factors that are involved, Doctor?
Yes, when we evaluate a patient, we get a total know-how of how good this patient's health is. And based on that, the American Society of Anesthesiologists, they have graded patients into 4 categories: grade 1, 2, 3, and 4. Grade 1 patients are the most healthy patients, whereas grade 4 patients are the sickest lot. So as the grade increases from 1 to 4, when we do a risk stratification, the risk increases. So the anesthetic plan and how we tailor the drugs during the perioperative period depends also on this grading. The sicker the patient, we need to be as precise as possible with the anesthetic. Whereas healthy patients, they have absolutely no risk at all. They belong to the grade 1 category.
Doctor, for example, there is an operation, there is a surgery on a patient X on a particular day. Okay. How do you prep them or prep yourself, or the kind of instructions that you give them?
Yeah. When a surgeon posts a particular patient for surgery, that is, he sees the patient and decides that this patient is to be posted for surgery, he refers the patient to us, and we do what we call a pre-anesthetic evaluation. This is a very important aspect because during this particular evaluation, we take the history from the patient so that we know about any systemic illnesses that the patient has, for example, asthma or high blood pressure or diabetes or any heart issue, whether the patient has any allergies, whether the patient has been smoking or drinking quite regularly or chewing tobacco, because all of this has a bearing on our anesthetic plan, and also whether the patient had any previous exposure to anesthesia, and if so, was the experience pleasant or was there any problem during the previous anesthetic, like a delayed awakening or awareness during anesthesia, or a lot of vomiting when the patient was waking up from anesthesia, or the patient woke up with a lot of pain or delirium. So these are all the factors that we take in terms of history. Then we conduct a detailed examination of the patient with specific reference to the heart rate, the blood pressure, oxygen saturation, heart sounds, lung sounds, and we examine the patient's airway and the spine. And we also look at the ease of venous access, because unless we put a needle into the vein, we don't have access to deliver anesthesia drugs. And then we also review the history of the medications that the patient is already taking, because some of these medications have to be continued on the morning of surgery and some have to be stopped.
Oh, yeah.
So based on all of these, we formulate an anesthetic plan. We discuss this with both the patient as well as the surgeon. And we give certain instructions to the patient. That is, on the day of surgery, how many hours they have to be totally fasting for, not eat or drink anything, which in an adult patient is typically around 6 hours. In addition, we tell them what medications they should take on the morning of surgery, what medications they should not take. And in the case of diabetic patients, we ask them to measure the blood sugar prior to anesthesia. And there are some more instructions which are surgery specific. Like, for example, we arrange blood just in case the surgeon has to transfuse blood during the surgery. And some patients may have artificial dentures. We ask them to take it off. And for some surgeries, you also need to prepare the bowel of the patient. The bowel has to be empty so that surgery can be facilitated quite easily. So these are the instructions we give. But I will end this particular answer by saying this. The most important aspect of allaying the anxiety of a patient prior to anesthesia is this pre-anesthetic evaluation. This is the time when the patient strikes a rapport with the anesthetist, and when the patient enters the theater on the morning of surgery, they are entering into an alien environment. They see the anesthetist, they recognize a friendly face, and they feel very comforted.
Doctor, you must also give the patients the anesthesia beyond the OT, and
Oh, yes.
I mean, at least managing acute pain. How does that work, doctor? When will such situations arise?
Yeah. Well, this has two parts to your question. One is what we do outside the theater. That is what we call NORA, or non-operating room anesthesia. Now, patients undergo several interventions, not just in the theaters, but also in the cath lab, in the endoscopy suite, in the radiology suite, such as a CT scan or MRI, or even a bronchoscopy suite. So in all of these places, the patient is worried about what is going on. So it is important that the anesthetist either gives them total anesthesia or gives them sedation, which is what we call monitored anesthesia care. So this is a very important aspect of anesthesia. Previously, it was believed that anesthetists worked behind the screen only in the operating theaters. But today, it's an accepted truth that anesthetists are also seen in areas outside the theater.
Yeah.
Now, the second part of your question is acute pain.
Right.
Now, there used to be a dictum which said, no pain, no gain. But as far as surgery in the modern day is concerned, the dictum is no pain, total gain.
Okay. Oh, okay.
So the patient cannot be allowed to complain of pain in the post-op period. So the anesthetist will combine several drugs and techniques to ensure that after the surgery is done, the patient wakes up with minimal or no pain. So this is what we call multimodal analgesia.
Oh. And also, doctor, going forward, I mean, in detail, for the anesthesiologists, how does the super specializations work?
Yes. When I graduated in 1991, we did not have any super specialization in anesthesia. Now, today, there are three ways in which budding anesthetists who have finished their training in anesthesia can further specialize.
Okay.
One option would be to opt for a one-year fellowship. It could be involving various subspecialties of anesthesia, like regional anesthesia, pediatric anesthesia, which deals with anesthesia for children, obstetric anesthesia, which deals with anesthesia for mothers coming in for childbirth, neuroanesthesia, which is anesthesia for brain surgeries, or cardiac anesthesia, which deals with anesthesia for heart surgeries, or transplant anesthesia. Now, the second option would be to go for a super specialization course, which we call DM, which follows ND. This is a 2-year course. So the options would be cardiac anesthesia or neuroanesthesia or trauma anesthesia or even critical care. Now, the third option is a little out of the way. Now, a lot of patients have chronic pain. And chronic pain could be because of your occupational factors, or it could be secondary to some sort of a disease. Most often it is because of cancer. So some anesthetists, they choose to become chronic pain physicians. They don't work in theaters anymore. They have chronic pain clinics and they dedicate themselves to treating chronic pain in these patients.
Okay.
So these are the various options that an anesthetist today has to super specialize in.
In such scenario, how are these two different, doctor, the super specialized anesthetist and also the general anesthesia person?
See, as you super specialize, your area of focus becomes very limited.
Okay.
Now, for example, you've done a DM in neuroanesthesia. You will get a job only as a neuroanesthetist. And you can only do neuroanesthesia for the rest of your life. Whereas a person who has an MD in anesthesia and has not super specialized further has a wider range of anesthesia to choose from. So that is the difference. But if I were a patient going in for a brain surgery,
Right.
and I had some knowledge of the super specialization that is there in anesthesia, I would ask my surgeon, does your anesthesia doctor who will be caring for me have any further specialization in neuroanesthesia? So that is the difference between a clinician who stopped with an MD and a clinician who's gone on to super specialize further in a particular field.
Correct. It's like narrowing down.
You narrow down your area of focus
Correct, I get it.
to one particular specialty.
And also, doctor, for patients who are very scared when they get into the operating theaters or when someone's giving them anesthesia, injection, etc., how do you calm them?
As I said, the rapport is first established when we do a pre-anesthetic evaluation. That is when we typically tell the patient what to expect when they enter the operating room. So that actually in most adult patients makes it so much more easy. But some people have needle stick phobia and some people have claustrophobia.
Okay.
Say for example, they can't take closed spaces.
Yes.
So
Like lifts.
I've seen so many patients who come for MRI. They just don't want to go into the MRI cabin.
Oh.
They want to be totally asleep before they go in. Or some patients have a needle stick phobia. That is, if you try to cannulate their IV, they simply won't cooperate with you.
Yeah.
So we have to employ a variety of techniques. The first and foremost would be a sympathetic talk. 9 times out of 10 it works. The other aspect would be to put some numbing gels which we place on the hand an hour prior to doing the injection, so that when the injection is actually made, they won't feel the pain at all.
They want an anesthesia for the anesthesia injection.
Oh yes, this is more common than we think. People with needle stick phobias. I mean, you normally have children who cannot take an injection, but then we see a lot of adults who can't also take an injection.
You're talking to one doctor, so I can totally empathize with that.
I can assure you, if you come to us, we'll take good care of you.
Thank you for that. However, doctor, what is a common complaint that you get from, say, the patients with regards to the anesthesia?
Well, one would be awareness during general anesthesia. See, when we put patients to sleep, we expect that when they wake up, they have no recollection of what went on in the theater.
Okay.
But in some instances, the patients are aware. When they wake up, they can recount the discussions that the doctors were having while the patient was asleep.
Oh my God.
So this sometimes happens when we give general anesthesia for childbirth, what we call a cesarean section.
Right.
Before the child is born, we keep the depth of anesthesia very low, because whatever anesthesia we give to the mother goes through the placenta into the child also.
Oh.
And the child will be born depressed.
Oh.
So as soon as the child is removed, we deepen the plane of anesthesia. So people undergoing cesarean sections under general anesthesia, they always complain of, not always, but most often complain of awareness.
Right.
And the second would be cardiac anesthesia, where we put the patient on a bypass pump. Even at that time, there have been instances where people recount what happened. So awareness is one issue with anesthesia. The second definitely would be pain. Pain after they wake up. So how we address that is important. The third would be nausea and vomiting. That is, they simply cannot stop throwing up. So we have to ensure that they don't have any nausea, because each time they retch, there is a stress on the surgical wound, and that enhances the pain. And the fourth would be difficulty breathing. The difficulty with breathing could be because their upper airway has not opened up as it should have, or the lungs are constricted. So these are various instances where the patients can have problem. And another common instance is when we do not catheterize the urinary bladder. During anesthesia, we give a lot of intravenous fluid to the patient. And when the patient wakes up, they feel that the bladder is full. But for a few hours, they are unable to pass urine. So that causes some distress. So these are all the aspects where patients can complain after they wake up.
Doctor, before I go to the next round, I have one question, just out of curiosity.
Okay.
Were there moments where a patient woke up in the middle of a surgery after you gave the anesthesia shot?
Touch wood, no.
No, okay, thank God. I'm just imagining, how would that be? But because I've seen videos where someone's playing a violin or...
Oh yes, sometimes it does happen, but touch wood, no. I mean, if you are quite careful, if you stick to your basics, this should not and will not happen.
Stick to the basics. Doctor, you just spoke like a cricket coach. Okay, now I have, like I said, the rapid care questions, Doctor.
Okay.
So I'm ready to shoot all those questions.
Whenever you're ready.
Let's go. Spinal, general or local? Your favorite anesthesia type to work with?
I would say general. Can I give an explanation for
Yeah,
this?
please, please.
Surgeons believe that God's best gift to mankind is general anesthesia.
And why?
Because patient is asleep. So they don't have to bother about whether the patient is moving or the patient is coughing or sneezing, or whether the patient is overhearing the conversations
All right. Yeah.
when the surgery is going on. You wouldn't believe it. There's a lot of conversation that goes on in the operating room. We discuss what's going on. For example, we could be discussing cricket or a film that we
While
saw
operating on a body?
on a patient. No, this is normal.
Okay.
This is very normal. You need to lighten the mood in the theater by engaging in some conversation from time to time, not to the extent where it distracts the surgeon.
I get it, yeah. It's just like to,
When there are
de-stress.
certain crucial steps, there is absolute silence, everybody is focused.
Correct.
But then there are times when we relax.
Yeah, I get it.
When the surgery is done, when the surgeon descrubs, and there is a bit of banter going on at that time.
Most common myth patients have about anesthesia.
That if you give them an injection in the back, it causes them pain in the back for life.
No.
A lot of patients have come to me and said this. 5 years ago, my uncle got an injection in the back and he's having severe pain till today. I mean, that is a myth we would like to bust.
Biggest misconception about anesthesiologists?
That they're very easygoing and they're more bothered about their coffee than the patient.
Clearly not in your case, doctor.
It really is not in anybody's case, but then the surgeon, when he's scrubbed, cannot descrub till he's done.
Right.
Whereas the anesthetist has the liberty of leaving the theater for a toilet break or a coffee break in between the surgeries when there is a replacement for the anesthetist. So the common banter between surgeons and anesthetists is that you guys are not as serious as we are.
You guys are having it easy.
Yeah.
Okay, that's definitely a misconception. Pre-op check or post-op monitoring, which is more critical?
Pre-op check, without any doubt, because that is what lays the foundation to the anesthesia plan.
Okay. The one thing patients forget to mention during pre-op assessment.
The one thing that people forget, there are lots of things actually that people forget, but I would say people usually cannot keep account of the medications they are on.
Oh.
See, for example, you ask a patient, very few will tell you, these are the medications I take, doctor, and this is the time at which I take it, and this doctor started this medication on so-and-so date. They will tell you, I am taking 4 or 5 medications, but I am not able to recollect all of them. I'll send it to you on WhatsApp after I go back home.
Which surgery requires the most complex anesthesia plan?
Any surgery involving a pregnant woman,
Oh, yes.
because 2 lives depend on that particular anesthesia and surgery. So I think that is one surgery where you need to have a very skilled anesthetist, and the other is when you do transplants.
Oh, yeah.
You have a normal patient, it could be the brother of a patient or a sister of a patient who's donating, for example, a kidney to the deceased person. They are doing it out of love, they are doing it out of affection. There is no monetary consideration here. And that is not a patient. He or she is a normal human being. And you cannot allow anything wrong to go in that patient.
Yeah.
Because they are doing something for a good cause.
Oh, yeah.
So these 2 instances, I would say, we require our best attention.
The most underrated skill an anesthesiologist must have?
Empathy.
You guys have more than empathy, doctor, I'm sure.
I wouldn't say it's very, very generalized, but this is something which is a work in progress.
All right.
Whenever we get juniors, we tell them, talking to the patients all the time and, keeping them without going into bouts of panic is very, very important.
Engaged.
So everything else is easy. I mean, cannulating an IV, getting an arterial line, putting in an endotracheal tube, but being able to speak to a patient in an empathetic manner, that is something I want all young anesthetists to be able to develop.
What's tougher, managing pain or managing expectations?
Managing expectations. Today especially, because of your mobile phones, everybody comes in with half knowledge.
How do you stay calm during high stakes critical care moments?
Well, that is something I have inculcated in myself because I believe the buck stops with me. And if I lose my cool, then coordinating treatment in a crisis situation becomes very difficult.
So true. One final question. One habit patients should follow pre-surgery.
Not forget the preoperative instructions that have been given by the anesthetist. I'll give you simple examples. We tell the patient, आप रात के 12 बजे के बाद कुछ मत खाइए. That fellow would have had 2 glasses of juice in the morning. And you'd ask them, मैं बताया ना आपको कुछ मत खाइए. He'll say, sir, आप कहे थे कुछ मत खाइए. आप थोड़ी बताए थे कि कुछ मत पीजिए. So, there are certain patients in whom we have to explain very clearly. So I think if they don't follow our orders, a part of the mistake also lies with us. So
They can be technical and get away.
Yeah. If you say don't eat anything and he says I didn't eat anything, he's right. He's technically right.
Oh, that was great, doctor. So thank you so much, doctor. I had a great time. And if there's anything that I missed and that you want to add on?
Nothing really. It's been a pleasure being here with you guys. Thank you so much.
Thank you so much, doctor. Hoping to see you soon.